Hi, this is Dr. Cliff Grunstead coming to the Cliff's Riffs, Dr. Cliff's Riffs. Today we're going to be talking about the amazing shoulder. We'll go through some of the anatomy, some of the possible pain generators, and some of the things you can do about it. So let's dive right into it. So the shoulder's an amazing joint. If you think about it, you can hang on to bars, swing from them, and your arm doesn't fly off your body. The professional athletes, like a professional baseball pitcher, has a angular velocity. In other words, the degrees of change of rotation of the shoulder up to 7,500 degrees per second, which is just amazing. And the key injury for a professional baseball player is actually not throwing the ball, but stopping the arm because it's going so fast, simply because the velocity of the full arm is so strong that it literally just pulls on the shoulder. The shoulder is really composed of mostly muscles that hold it onto the body. There's no deep socket inside the shoulder joint. It's a fairly shallow joint. Here's an x-ray. You can see it's just got a small little cup that holds the arm bone that it rotates on top of, unlike, say, the hip joint, which has a fairly deep socket, and other joints which are fairly well stabilized. The shoulder joint is really held on by muscles and ligaments for the most part. And there's two motions that occur. You can have motion at this, what's called the glenohumeral joint, where your arm bone connects to your shoulder bone. And also you have the shoulder blade called the scapula, which will rotate up and swing up so that it will rotate up to allow you the full stretch. The key elements that hold this arm onto your body are the deep ligaments, the deeper muscles, and then the large superficial muscles that will move the arm in a strong way, like the deltoid. We'll talk about that in a minute. But the key thing is that this joint is incredibly flexible, and you can literally move it anywhere in your body, assuming it still has the range of motion and it's not hurting you and not locked up. But you can touch anywhere except inside your body. It's so flexible. Because of the flexibility, it also leads to instability, which is really the main problem with it. So as you add more layers of ligaments, muscles, almost like duct tape holding on to the arm, that's what provides the stability and also causes some of the instability when some of these things go awry. The large muscles of the shoulder, like the deltoid, are the main movers of the arm and the shoulder. We call them the beach muscles, or the mirror muscles for muscle builders that are staring at themselves in the mirror, looking at the big contours of these muscles. Those are the main superficial movers of the arm, but the deep internal muscles of the rotator cuff, you may have heard that term, sit and hold the muscle, hold the bone, the arm bone, onto the shoulder blade, like almost like a cup of a pole vaulter. When he puts the cup in, the pole into the cup and pivots off of that cup, the rotator cuff pulls the arm bone into that glenohumeral joint, like we had showed before, pulls the head of the humerus in so that the deltoid can lift the arm up, pivoting on this little sideways golf tee of the shape of the shoulder joint. So the idea that you just have to have big deltoids is a fallacy, because the deltoid, again, and the large external muscles, the pectoralis, and some of the posterior shoulder muscles, the trapezius, those are movers, but they're not really the stabilizers. What can happen when you have instability in the shoulder, if it's jiggling around, in other words, if you have the head of the humerus moving on this small little joint, it can start to bang up against the surface or the roof of the shoulder, which is called the acromion, and that bone oftentimes will cause irritation to the rotator cuff tendons that are sliding underneath. And also there's a bursa sac. There's this little lubricated fluid sac that allows the muscles to slide underneath that little bony shelf so that it doesn't get pinched too much. And it's very common for that bursa to get inflamed, to get irritated. And it's oftentimes present when you reach behind your head. Say if you're reaching to scratch your back or behind your back like this, anytime you're rotating the shoulder back or reaching up above shoulder height, it will sometimes pinch that bursa and cause problem. What's interesting about the arm is the shape of the arm bone is a little bit oval. So when your hand is down and you lift your arm up, you can only go so far. But if you rotate your hand up towards the sky, now your arm will move further because it's limited by the shape of the bone. So you can try this. Have your thumb down, point up. You can only go so far, but if you rotate your arm, now it will go up towards your ear. So that causes some of that irritation to the bursa that sits deep in the shoulder. The other possibility is you can get some tearing of the rotator cuff, either irritation or frank tearing. So the irritation can be almost like fabric on the knees of your jeans, and the fabric starts to thin out to the point where it actually rips or tears, and you can get small little micro tears. You can get larger partial tears, or you can get what's called a full thickness tear, where the entire tendon of the muscle will just rip, it retracts away, and now you don't have that stabilizing force of the rotator cuff holding the arm bone into the glenoid, onto that sideways golf tee, so that it's kind of wiggling around on top of the golf tee, and that causes some instability. It might then wear out the shoulder, and then you start to get a little bit of narrowing inside of the shoulder joint. You can see in this picture, the x-ray compared to this normal looking x-ray of the shoulder, you can see the humeral head sits right on this little micro curved surface. But on this one, you can see that the arm is shifted up a little bit. That's because the rotator cuff is likely torn and it's not being stabilized, so it actually migrates up. It hits its head on the roof of this shoulder called the acromion, and then you end up with some bursitis, some pain from the rotator cuff, or you actually start to wear out the cartilage inside the joint. In this x-ray, you can see that the joint space narrowing has been eliminated. You can see there's a little bit of a space up on the top part up here, but then on the bottom you can see there's no spacing, there's no cartilage left, and sometimes it goes to the point where the humeral head will start to change shape, and sometimes if it just goes on for a long time, it just gets ugly, and it's a totally worn out shoulder. Not much you can do with that one. Then the only recourse for this kind of situation would be surgery. So then you can get some hardware replacing the shoulder. But a lot of times, if you catch it early enough, you can find that the small little tendon tears can be calmed down with some anti-inflammatories, proper exercise, posture, so you're not pinching your shoulder when you're doing activities, and sometimes the shoulder will respond well to corticosteroids, but you don't want to do that too much because that can cause some degradation or some thinning of the cartilage in the joint. In the bursa itself, it's usually pretty benign, but if you inject into a joint with cartilage a lot, it may soften and degrade the cartilage and actually cause arthritis. But the corticosteroids are a good rescue for an acute situation. You can also start to get this. You can see here, it's a little bit of a messy MRI, but you can see this little white, bright geyser sign, we call it. That means that you've got a full thickness tear in the rotator cuff, and the fluid inside of the shoulder joint is going through the hole of the rotator cuff and popping up towards the surface of the skin. You can oftentimes see this best with ultrasound. We do a lot of that here, where you can see the bone, the ligaments, the tendons, and the bursa, and you can actually see it dynamically move, which is really the beauty of ultrasound, because MRI and X-rays require a very still image, but the ultrasound is very useful for looking at what recreates the pain, what is the tissue doing, how does it move, does fluid collect in a certain area, is the labrum, which is like a little gasket around the joint, the bone, to make it a little bit deeper, is that torn and unstable? So the dynamic ultrasound imaging is fantastic for looking at shoulders, and it may just save you the cost of MRIs. It's purely there's no X-ray, and it's immediate results. So the other possible sources of pain, besides just the orthopedic ones, the worn out joints, the worn out tendons, the bursa, or even a fracture or arthritis, you may have some referred pain from the neck. There's a saying that necks cause shoulder pain and shoulders can cause neck pain. But the key thing is to get a careful evaluation to make sure that your shoulder pain isn't originating from your spine. It's not uncommon that we see some pinched nerves in the neck that will radiate to the shoulder or to your shoulder blade, the scapula, and that's actually originating from the neck area and the pinched nerves, not from the shoulder itself. Sometimes people will go to massage therapists, or they treat the tightened muscle, the spasms and things like that, but they're chasing the victim of the process. The culprit is higher up. It might be something as simple, if you can see this little x-ray, but there's some bone spurs that are sticking out inside of the hole where the nerves come out. Here's a little hole where the nerves exit the spine, and this one has gotten quite narrow, as has this one a little bit, and it can jab at the nerve as it's coming out of the spine just by having these little bone spurs that are sticking, that have grown onto the vertebrae. You can also have a disc herniation, a little protrusion that comes out, irritates the nerve root, refers it down to the shoulder, and that's a totally different treatment if it's nerve pain from orthopedic shoulder pain. So make sure you've got the right diagnosis, and most definitely make sure that it's not something which is absolute dangerous or life-threatening, like a heart attack. You've heard of people having, arm pain with a heart attack, and there's a certain pattern for that type of shoulder pain, because it usually is not movement dependent. It's not if you move your neck or your shoulder. It has mostly to do with exercise. If you're exerting yourself or just sitting there doing nothing and you feel some arm pain, you always want to make sure it's not something a little bit more serious, like heart disease, or even referred from the chest, or even sometimes from the abdomen, which can refer up to the shoulder. That type of pain usually does not change if you're, like I said, moving the body, but it's definitely something to rule out. So don't assume anything unless you really know it's not that. So what do you do about the orthopedic side of a shoulder problem? Well, physical therapy, exercise is the number one treatment of choice. Anti-inflammatory and pain medications can be helpful for a short run, just to kind of calm things down. The key thing is learning how to exercise correctly. You don't want to just go and start making yourself strong, lift weights, and do it wrong. For example, in this example of this young man lifting, the way his hand is positioned down is actually going to cause pinching of that bursa and the rotator cuff in that shoulder. So this is a better position where your hand is facing your body. When you're lifting weights, you want to lift it so it's always facing you so you can lift it up. If you have your hand away from you, it will pinch and it will start to irritate the shoulder structures like the bursa and the rotator cuff. And the other possibilities, more advanced treatments, you can inject the shoulder with different medications. like we talked about, anti-inflammatories like corticosteroids. You can use a liquid Motrin type medicine called Toradol, which sometimes is an anti-inflammatory, which is not a steroid, but it can calm down inflammation as long as you're a candidate for that type of medication. And then there's also the platelet-rich plasma we talked about, regenerative medicine, where you can put in concentrated platelets which carry little packets of growth factors that can heal tendons and ligaments. The cartilage you can use it for a shoulder that's wearing out a little bit, but if it's totally bone on bone, no cartilage left, the PRP injections probably won't help you. But if you're having some arthritic pain, if you have crunching and clicking in the shoulder, it may be worth trying a PRP injection to see if that helps you. You can also do some of the advanced things we do at Spine West, which includes these cauterizing the nerves of the small little nerves of the neck. Not the big nerves that go into your arm, but they're small sensory nerves, which will give feeling to the little joints back here. And sometimes those facet joints will cause pain. And we can kind of clip those without surgery, and that can provide up to a year's worth of pain relief. But you start to get into the more advanced interventional type of things. So there's many treatment options, not just surgery and not surgery. There's lots of tools in the toolbox that you can try depending on what the condition is. The primary concern is what is the diagnosis, what's causing that pain in the shoulder, and get that clarified so then you can make an appropriate treatment plan for going forward. And that may include standing up straight and using good posture, exercising correctly like we talked about, and all those types of basic things, which may be enough to just calm you down. So I hope that helps you with the overview of the shoulder. The key thing is know what you're doing. Don't just ask Dr. Google and think you have a diagnosis. You want to make sure there's nothing dangerous going on. Hope you're enjoying these little Dr. Cliff's Riffs YouTube live videos. If you have any suggestions for us, let us know. Enjoy life. We'll see you next time. Take care.